Good morning, class. This is going to be chapter 1. I tried lecturing outside, it's still a little bit cold, so we'll do it here. Go ahead and get this PowerPoint. All right, so chapter 1, going to be a lot of vocabulary. Just get into, well, I have a list right here. Get into diseases, some major kind of categories of diseases, and get to care of patients, kind of some big picture stuff. So let's get right to it. So disease, ease, dis-ease, lack of ease. So it's going to be some structural or functional change that's harmful. So you can have other changes like growth and being pregnant, things like that, that are indeed changes, but they're not necessarily harmful. So it's not a disease. So these things can be at the cellular level. We'll get to all the different categories of what can cause this disease or lack of ease in your body. But whatever changes are going to help you prevent you from acting optimally. Sorry. And it is interesting looking at treatments and what is, the definition of disease, depending on the culture, at what point you seek medical attention. And yeah, there's some, we tend to look at things from our own perspective, our own experience going to our doctors or whatever we do, but realize you could be dealing with patients with a really different background. So I made this slide here. Of course, imagine someone comes to you and tells you that they're very sick because they're possessed by the spirit of their evil grandmother, and they're just going to die. It doesn't help to belittle that. I mean, between you and me, they're not possessed by anything. But you need to just understand that and put it into context of your modern medical training. See a lot of this. I was just fighting on Facebook with someone talking about how vaccines harm more people than COVID. It's just nowadays, especially with social media, you can get on and online, you can get on and just read all kinds of ridiculous, unsubstantiated claims. But people are going to be coming to you with these all the time. Relatives, friends are going to, they look this up, they're experts. But one thing, alternative medicine, when you hear that, like, I'm just do alternative medicine. That just means you're using medicine that hasn't been proven or has no evidence that it works. And once, these things, like maybe you have, herbal remedy, something new, once this treatment works, then it's medicine. That's it. Then there's not big pharma, the man hiding these things. I mean, I guess some people saying marijuana cures cancer, does all these things, but we're just not, not letting the public know. Well, if it worked, then it would be someone want to make money by making it into a therapy or a pharmaceutical. So really, these conspiracy claims are just really hard for me to swallow. And so, but there are things, cutting edge. Maybe you're using, something that is brand new but needs to be tested. For evidence-based medicine that we're using, you need to have tests. You need people with placebos and with the actual treatment, and you need to show statistically that it does something. And what's interesting is that you can have things that make claims to improve your health, and even a placebo, a sugar pill, something that has no active ingredients. You get a group of people and you give them a placebo, but they think it's medicine. They actually can have better outcomes with anything. So you're probably saying, well, what's the harm then? Just, they believe it works. Well, there's just, you can't just, make claims, about anything without any, proof behind them. It's just, it just gets washed out with the real therapies. But if anything makes you feel better and reduces your stress, your immune system will work better, because when you're stressed, you have cortisol, hormones coming out that are going to lower your immune system. So it's true, you can make a claim anything, you sniff lavender or vanilla scent and it makes you feel more relaxed, you're actually going to be able to fight off infection more. So in that sense, you can see how someone can make a claim about just about anything that it has beneficial effect, but we don't hawk cures that are not real, right? All right. There you go to that. So you will see different cultural backgrounds. That people will bring in things that don't make any scientific sense. Oh, there's Gwyneth Paltrow in her egg. You can look that up your own. I don't think I'll let you enjoy that. But these claims that you can make, there's a lot of really crazy ones out there, and so you need to take what you hear from a patient and try to put it in your context of scientific thinking, without belittling someone's beliefs, of course. So disease. And of course, allopathic medicine is the idea of evidence-based medicine, Western medicine, the idea that in order to suggest a therapy or a drug or something like that, you have to know that it works. It has to have some basis, some evidence for that. There has to be tests that show that it works. So we don't talk about evil spirits and ghosts and energy fields, and you'll see a lot of this if even you look at things like acupuncture and some aspects of chiropractic, the part where they can try to cure diseases besides musculoskeletal things that are just overreaching in terms of evidence that they do something. And you need a test. You need to show a double-blind study that your therapy statistically improves people more than not. That's certainly my basis of why I don't carry around a rabbit's foot or something like that. So disease, we believe it can be, explained by some kind of changes, either physically chemical changes in the body that throw off your homeostasis, and your body has to react, and it has negative impacts. There you go. And now even molecular level, looking, of course, at your genes, often the cause or contributing factor to disease. So pathos, meaning suffering, ology, like study of, like biology is a study of life. So pathology is a study of disease and suffering. Well, not suffering, disease, okay. And when you look at the course of a disease, that's its pathogenesis, like Genesis in the Bible, to create. So it's the path of a disease. And studying this is pathophysiology, right? Pathology is some kind of disease state, and pathophysiology is looking at the mechanism of how that is working. Another term for you is etiology, as the cause of the disease. So you need to know that term. What's the etiology? What's going on behind the scenes? Pathology, you'll hear that is also is a branch of medicine, and people will study samples, tissue samples, bring it to a pathologist, or do an autopsy, look at pathology of a dead person, looking at to see the cause of death there. Here, I'll show you a kind of a list how you can break down different kinds of pathology. So anatomic, of course, we're looking at doing autopsies. So post-mortem, look at the body and try to see what happened. Surgical pathologists will get even in the middle of a surgery, they'll take a tissue sample and they'll send it down and make a quick slide and take a look at it, and then they can call up and say, oh, you got all the cancer or not, something like that. Cytopathology, cyto means cell. So cytopathologists are mainly, a lot of it is cancer. They look at like a pap smear, looking at cervical cells to see if they have cancer. So it's looking at that. And then clinically, you can see chemical, microbiological, hematology is blood, immunopathology, even molecular diagnosis, where they take a look at your genes, look at your DNA. So many different levels, from research and teaching to gross anatomy, to cytology, looking at the cells, to people doing laboratory tests on tissues. Manifestation of disease is going to be how it manifests itself. How does it present itself? And what you do is there's a difference between symptoms and signs. Symptoms are what a patient reports. And some of these things you can't observe as a nurse or as a clinician. They talk about pain. Pain is very subjective. Talk about lack of sleep, or I feel nauseous. Can you tell me that I feel nauseous? Can you do a test? No, I can just tell you I feel nauseous, right? So these things like that are symptoms that the patient will describe. Signs are observations made by an examiner. So you're doing a physical examination, you see, oh, they have that bruise, they have that rash, their voice changed. All these kind of things are signs that can be written down and can be observed. And then laboratory work, you can do radiographic, like they need an x-ray, let's do an MRI, or let's do a CBC, let's look at a blood count, let's do those kind of laboratory tests. And putting together signs, symptoms, laboratory tests that you order, you can start to make a diagnosis, right? So diagnosis is when you assimilate all the information you get. And the patient history is when you talk to the patient, you talked about their background, when they started feeling this, what's their social situation even, or family history of disease, all these things. So you get this history, and again, you guys watch the show House, but patients lie, you know, and there's a difference between you know, getting facts and hearing someone tell you something, but of course, but you take them anyway, and then you put together with the physical examination, signs that you notice, and then any tests that were done, and you put them together and you come up with a list of what you think the disease could be your diagnosis. And differential diagnosis, you start narrowing it down. And when you come to a couple diseases that could be a result, you know, these signs could be from several diseases, and then you start finding tests to knock one of those off. So you're left with just the diagnosis. So the diagnosis is the disease. You have MS, broken femur. You know, that's going to be the diagnosis. And sometimes it's tough. You get on nondescript symptoms and signs that could be caused by a whole constellation of diseases, and you try to narrow it down, but sometimes you ended up to just kind of they had these symptoms and it could be several diseases, so tentatively you put some diagnosis, but maybe it needs time for the disease to progress before you can make a definitive diagnosis. And Alzheimer's is one where we see dementia and you get signs of it, but really the only confirmation is when you do a look at the brain and see what's going on there with the plaques and the tangles. And so that diagnosis of Alzheimer's is usually tentative. You have Alzheimer's type dementia, and then you can nail it down when you find certain with a brain biopsy. And then a syndrome, you'll see that used for a whole bunch of the symptoms and signs point to an issue where there could be several causes, but so you talk about a syndrome. So example, nephrotic syndrome. Nephron is your kidney, right? And so if you have protein in your urine and edema and other high nitrogen levels in your blood, it's indicative that there's a kidney problem, but you know, you haven't nailed down what the proximal causes. All right, and diseases, we'll talk about structural and functional. So structural, there's going to be some, you'll see some changes in the body. And we're talking about lesions as being any kind of structural, any issue. That's a term used quite a bit. And you can break down these structural diseases, genetic and developmental. So of course, could have Down syndrome, trisomy 21, where you have an extra chromosome. Developmental diseases that arise in development as well, and then degenerative and inflammatory diseases and trauma. Obviously, it's going to be some kind of gross injury, and it could be caused either from the external environment. You could have an infection kind of thing, or it could be some kind of vascular or disease within you. When you hear neoplasm, it's going to be a whole chapter we'll get to. these will be, if it's malignant and spreads, it's a cancer. So it's going to be, neoplasm will be a cell line that has just dividing uncontrollably, right? And hyperplasia is when you have cells that divide, but it's usually some kind of external influence, and then you can remove that and they stop dividing. When you're pregnant, your uterus, the smooth muscle has hyperplasia, it just grows like crazy to get so much bigger. So in a neoplasm is when you have a genetic change that causes kind of a cancer line of cells. In functional diseases, you don't see any lesion, any obvious thing, but there's the functioning is off. So if you have diabetes or hypertension, you clearly have a problem, a disease, but you can't look and say, where is that high blood pressure? You can measure the pressure in your vascular system. And it can lead to lesions in the future. Diabetes, you can look later, you can see in the blood vessels that there's physical signs, but functional diseases is where there's going to be some physiological change. Talk about a headache like that, or irritable bowel syndrome. These things are caused by the nervous system causing this, and so you can't, there's nothing, no lesion you can point to like a broken bone. All right, so what causes diseases? Some terms are exogenous and endogenous, right? Ex from the outside, external, and endo meaning inside. And so, of course, exogenous could be some trauma, you get in a car accident. Physically, yes, extreme heat, extreme cold, electricity, radiation kind of thing. Chemicals, it can be poisoning, and then is it accidental? Is it homicide, suicide, that kind of thing? Or drug reactions can cause chemical problems. And then microbiologic is infections. So bacteria, viruses, other things that fungi. Yeah, so from the outside, you can be infected. You can have chemical or physical issues that cause this problem. That's from your book, take a look. Yeah. And microbiology, I mentioned, bacteria and viruses are the big ones, but you have some other less common culprits that cause disease as well. Yeah. And chemically, I talked about poisons and drug interactions, but the big thing is environmental toxins too. You could expose to pesticides, things like that. Yeah. Endogenous. So this is not an external kind of thing. So it could be a vascular disease where you have atherosclerosis, hardening of the arteries. MI is myocardial infarction, heart attack, can be caused by atherosclerosis and a clot like that. Immunologic, so it's within your body. You can have autoimmune disease like lupus or rheumatoid arthritis, where your body is attacking itself, MS. And allergies too, where you have your body is just overreacting its immune system. Or it could be a metabolic disease. And I found this table, all kinds of metabolic diseases where you have issues internally with your metabolism. It's not, bacteria or something, the external environment attacking you. Cool. Yeah. So vascular, yeah, immunologic, and a metabolic issue that's causing you to have a disease. All right, here's 3 terms for you. I can almost promise you're going to see these terms on the tests, quizzes, right? So this is chapter 1, we get our vocabulary down. So if you have a disease and we don't know the cause, it's idiopathic. So you hear that. And you look at an example, we look at a disease and we don't know the cause. You have this MS, idiopathic, we can't point to a culprit. If we do, then we can come up with a diagnosis of that. Iatrogenic, I don't use that term very often, but that is a disease caused by the treatment, by our medical treatment. And so you'll see these kind of things. Sometimes you'll get a Cushing's syndrome because we prescribe too many steroids. And so that is this kind of disease. Because we actually cause this by giving steroids for some other issue. Nosocomial, This is really big in the hospital environment. This is hospital-acquired infections. Think about MRSA, and you think about C. diff, those work in a hospital. These are things that, going to the hospital, there's a lot of sick people there, right? And that's why people aren't going to the hospital now. They're worried about COVID. I mean, that's many hospitals, they hold a lot of them. So they're putting off a lot of routine hospital care these days. So nosocomial diseases, they try to prevent those in hospitals by sanitation, hand washing, all these things. So in allopathic medicine, which is modern medicine based on evidence-based medicine, Western medicine, you're familiar with this. You guys, all of you are familiar with this. You take a patient history, but again, this is, they can lie, but they hear about their symptoms, why they're there, and then the physical exam, these would be signs that you are observing. And then you decide what tests are needed, depending on your initial diagnosis, where you think you're going with this, right? If it's some kind of upper respiratory, maybe you need a swab, you need to see do we have strep, something like that. If they have pain in an elbow, maybe they need an x-ray, maybe it's soft tissue, an MRI. So that's where your judgment comes in to see what tests will lead you to the diagnosis. And differential diagnosis, so you write out a whole list of things. It can be these, and then you figure out, using logic, what tests will allow you to rule things out so you're left with just one. And that would be the diagnosis. Yes, very good. And of course, follow-up is very important. You don't just say, good luck, I wonder if they made it. Wonder if I helped, you want to hear back from them. You want to see, you want to bother to make sure they're taking medication or therapy, whatever you told them to, and you want to see how they're doing, right? And so and you also do this just to gather data to see, if this helped you, can we learn from it and help other patients the same way? And if there's complications, or of course, complications are secondary problems that come about, possibly because of your treatment or things that were just unforeseen. Indeed. So a diagnosis is what you're looking for. You're going to sum up the problem, and there can be multiple diseases going on at once, right? And then you want to give them a prognosis, which is your guess, or educated guess, your idea about, could be survival, or it could just be how you expect this disease to progress, how their life is going to change based on other people that have had the same diagnosis. Okay? You hope the treatment that you use has been tested, has been looked at, has been published, papers about it to show that if you give X treatment, it is the best for this person with the following symptoms in the following age group. So that's how we guide our treatment, is looking at best practices based on science and studies. And our hope, diagnosing a disease for some, that's it, I solved the problem, right? But then the next thing is the treatment. And what we're trying to do is stop the disease. Sometimes you can't. Yeah, and then you simply want to just maybe manage the symptoms. So that's what we're looking for, is to manage the symptoms or stop the disease as soon as possible to give the person the best quality of life. Yeah, goal depends on the disease, right? Sometimes you just want to make them comfortable if the disease is terminal. So yes, as I say, the care of patients, follow-up is critical. You want to monitor them, and whether they're adherent. When you hear adherence, that means is the patient following your advice? Are they taking the medication? And that can be a challenge for many reasons. And as I said, the reason why we do a follow-up and we write reports and we send in information is so that help guide our future patients. So, we've been doing this a long time, but COVID comes in, and right now it's few months old. We're learning what works, what doesn't work. The only way we know this is by reporting information accurately. All right, so I wrote this a little bit of a redder color, looking at a few slides, looking at obstacles to patient care. Well, there's going to be obstacles depending on the particular disease. There's some diseases that are trickier than others. Some are quite simple. Take an antibiotic, you get rid of some things. Availability of resources. What kind of place are you in? And now, right now, of course, we have personal protective equipment and test kits for looking at COVID. Patient care is limited by that. We would like to test people that we can't because it's just we don't have the resources. In other cases, there's drugs that are out of reach financially. That here you have a patient that could really benefit from this drug, but it's super expensive. It's a brand new kind of thing, and if they can't afford it, you can't just blindly prescribe anything, knowing the realities of the situation, right? And yes, the disease process definitely can be complex. And again, I'm going to talk about it in lecture 2, looking at our life expectancy and how it's gone from the living to be in your 50s to now living to be in your 80s over less than 100 years. And it's not because of fancy technology. It's because we have learned about stopping infectious diseases. And when you look at average lifespan, I should make this point too. One way to increase the average lifespan is to end childhood death, because it's an average, right? And so what we've really done, there were people in the Middle Ages that lived to be 100 years old, but there was a very good chance in the Middle Ages you didn't make it out of your teens because you died of plague or cholera or something like that. So we're really good at preventing early death, and that lifts the average up, way up in our terms of life expectancy. So there was people that lived over 100, way back when. That's not the key. There seems to be a finite human lifespan, 120 some years beyond that. We got millions of data points. People just don't make it past that. But we've increased our average by ending really communicable, simple diseases because of vaccines. We figured out vaccine people early on. It gets rid of these major diseases like polio and measles and whooping cough and mumps. People are not dying of those because we know how to prevent them. And basics of sanitation and nutrition and understanding toxic environments. So we've gotten good at that. That's how we've, in the modern world, we have a healthier society that lives longer on average. It's not because of the, learning to make an artificial heart. It's because of simple things like clean water and getting your shots. And yeah, this is, of course, today, so much misinformation about health. Definitely, it's so hard to get people to comply with, even if you know what's the best practice. It's this. I don't want to get into it. We have this culture of that ignorance is something. Listen, got to go off on a tangent, but that we look at people like, we often look at two sides of the situation. We always say that, well, okay, like we look at climate change, and then is it real or not? We need to bring an expert from both, but no, you don't. Not everyone's opinion is equally valid. I know you're just sitting back like, what do you mean? It's true. You're going to take the advice of a medical professional or someone that just did a Google search. Not only that, medical professionals around the world, all of them that have devoted their life and taken all these classes and study this. Do you believe them, or do you believe someone that has a feeling about it? Those two people are not equal. You don't have to give them equal time. So that's a big problem in America, is people giving any idiots saying that their opinion is equally valid as an expert, and that's not true. All right, I digress. Yeah, and what we see here too is you look at the haves and the have-nots. I'm going to talk in lecture 2 about the uninsured and how the richest country in the nation, we have this huge divide between haves and have-nots. And I get twice a year screenings for my teeth. I go to a doctor every year. I get a flu shot every year. There are people not far from me here in rural Maine that can't have any of those. No, they'll go to the emergency department if they're going to almost dying, or that's the reality in our society. And as an example too, we're working on a vaccine for COVID-19, and you say to yourself, that's great, and then we can afford it, we can make it, give it to all Americans. But if we don't vaccinate the other countries, it's just going to come back. And so it needs to be a world. We need to work together in the whole world, because we need to give countries that can't afford it. We need to support that. We need to get that for free. And we're going to have to pay for it, the richer nations, if we want a world where we get rid of this disease. So we're now in a global society where we can't just think that we're isolated. Viruses don't know any borders, and even no wall is going to keep it out. There's too much movement in the world. So something to think about. And it's amazing looking at this lag between what we find and when it actually, the society adopts it. Indeed, this is an example here of smoking. I mean, this is, you look at smoking over the years, you can see they were giving out cigarettes World War II, keep you alert, And then we found out that it was Surgeon General report back in the 60s. Oh my God, smoking causes lung cancer, causes all these problems. You think, okay, 1966, 67, smoking ends. Oh, no. Here we are, 2020, still people smoking cigarettes after, a more recent report came out showing it causes diabetes and all kinds of cancers and low birth weight in children and all these things. And secondhand smoke is dangerous. And so, yeah, taking these discoveries and the lag time between people finally catching up to it is frustrating for sure. Not adhered to, definitely. We have healthcare providers out there that kid comes in with an ear infection or cold, they give them antibiotics, even though there's no way. They're useless for a viral disease, as you guys know. It's just, I guess, easier. It's just, there should be, everyone needs to have the same standards, and that is harmful. We know so much hypertension and blood pressure, which is going to contribute to a lot of diseases like stroke and heart attack and all kinds of things. So much of that is left untreated out there. And so we know what should be there, but how do we reach that goal? There's obstacles to that. And then next one talks about how patients it's good to get a second opinion, but then when they get a different opinion, it's frustrating for everyone involved. And so that's another obstacle when you have patients don't know how to trust and doctors are frustrated to get different. Obviously, you want as much information as possible. It's good, but there's frustration there when there's heads butting like that. And then, of course, your treatment is really going to vary depending on where you go. You don't want to say that. In America, you want to say you can go anywhere and get the same treatment. But if you have some rare disease, you're not going to be treated well in a clinic overworked in the inner city that's maybe more involved with preventative measures or in a rural community that doesn't see many patients. You obviously want to be in a large research hospital if you happen to get something that's rare that they specialize in, right? And yeah, and your age, many things are going to influence your treatment. There's a lot of subtle things there, whether you have insurance or not. It shouldn't, of course, but it's going to be a factor. So, as you've heard from me, the United States, one of the richest countries. We have the best scientists. I say the best scientists. We have the most science infrastructure. We publish the most scientific papers in the world, of any country in the world. Yet we spend more on healthcare per person than most other countries. Why is that? And then you would think, okay, well, we have the best healthcare. We don't. We are not up there. We are way down the list in terms of birth complications, looking at people dying of diabetes, even life expectancy. You think, oh, US #1, life expectancy is lower in America than other countries. So why is this? This seems like a dichotomy, right? Best science, rich nation, low health care outcomes. I underlined it. Inequitable distribution of resources. First of all, we have our healthcare is for profit. So we have a whole middle layer where the money goes to pay for all these insurance issues that are just removed in most countries where you have the medicine and the people paying it. You don't have this whole group of people deciding where the money goes. So indeed, it's that inequitable distribution, lack of good health education, and like I say, we have really two Americas, the haves and the have-nots. Interesting too, at the end, we talk about healthcare budgets, is that this is a lot of these things are fascinating. Looking at the what am I trying to say? We're looking at, for instance, when you have how we deal with terminally ill patients is interesting, and how we deal with death too. Yeah, some strange things is that how much money do you spend at the end of life to prolong life? And should our focus be on prolonging life as long as possible, no matter what the cost and no matter what the quality of life? Ethical, medical, yes, ethical dilemmas. That's the word I was looking for. So should we let people die with dignity? And, should we allow euthanasia or end of life if your quality of life is so poor? Do we need to put you on so many chemicals and ventilators and such just to keep your body alive? Because that should be our goal. Yeah, the great stuff. I mean, you guys will take classes on this. I just taken this opportunity because I love to think about things like this. But when we look at it, when someone steps back big picture, many times we spend millions of dollars on terminally ill end of life care when we should really, as a society, I believe, just embrace death as something that's going to happen. And I don't want to say not fight hard against death, because of course no one wants to die, but just take a bigger picture and what's the quality of life, and should the resources and should the suffering be there when it's doesn't need to be. You guys, you all have your own opinions. When you hear me talk about these things, I'm giving you my outlook on it. All right, and lastly, so being lecture one, looking at the text, it's a beautiful thing. You're going to see vocabulary. Just make sure you know all those words: idiopathic, nosocomial, things I talked about this lecture, diagnosis, prognosis, all these things. So you know all those. This is the intro stuff, but we'll get to specific disease. We'll get to heart and to lungs. And so we're going to talk about major diseases, you can understand the cause and what we can do about them for each one of these. That's the meat of this course. So we'll end up at the beginning here talking about big picture things this week. And then, God, that's all. We're really going to quickly get into each organ system. So we're going to get to I don't say the good stuff. This is good too, but it's putting everything in context. And then lastly, at the end, we'll talk about some diseases that are not just one organ system, but are kind of multi-organ systems. And so, yep, each chapter, again, you want to has the outline of what you need to learn. And again, this first test, 10 chapters, you mean this first test. So you need to use your time wisely. You have time to read the chapter, to listen to these, to take notes, to work with it. The practice questions at the end of the chapter, this morning, I took the answers. I have the answers and I cut and paste them. And I put it under the first chapter 1 folder. It'll say answers to practice questions, chapters 1 through 10. So they're all there and it shows what page they're on. So you can do those practice questions. They'll be really similar. So the exam will be like those practice questions, like the quiz questions. It's going to be multiple choice, true, false. It'll be timed, and make sure you understand the vocabulary and the basic concepts that I've done. That's how you're going to prepare. And I'll talk a little bit more near the end of next week, but it'll be a time test. Of course, you're all interested. How is this class being assessed? I want you out there studying this. I already talked about how important it is that you learn this information. And then I'll put up these assessments to test you to see, that's my job, to see if you have sufficiently taken this information and put it into your brain. All right. So that's chapter 1, big picture things. Chapter 2, we get into the major diseases, things you're going to find, but got some good vocabulary, talked about patient care and some big picture things. All right. I think that's all for this morning, and excited to move on and get to actual disease states.